Right, so what is autoimmune encephalitis? Well, first of all, encephalitis of itself simply means inflammation of the brain, and autoimmune is one cause of that inflammation. Autoimmune encephalitis has been known for a while, going back for a couple of decades now, and probably accounts for at least half, if not more, of encephalitis cases, with an incidence of about 10 per 100,000 per million per year. So we now think that it's probably at least as prevalent, if not more so, than infectious encephalitis, but data are still emerging. However, as we've said, incidence now is comparable to infectious encephalitis. So a typical start will be symptoms coming on over about 2 to 3 months, or maybe over a few weeks. And the kind of classical symptoms would include seizures, cognitive changes, so sort of memory, forgetfulness, and psychiatric changes. So things like personality change, not really being the sort of same person as the family knew before. And the main cause is sorry, I'm just watching all these slides. I'm really sorry. It's very slightly off-putting. So what happens is the immune system, instead of responding to microbes and viruses in the environment, it's turning against itself. So our immune system is attacking itself and attacking tissues that are in the central nervous system. And as, let me just see if I can now get onto the next slide. Right, finally. As this slide shows, the difficulties are multifaceted, causing all sorts of difficult problems, and there's also a significant socioeconomic impact. Okay. There's some builds on this slide. Let me get everything up in one go. So as I've said, autoimmune encephalitis is caused by our immune system going wrong. So normally these cells here, which are white blood cells, our body produces those to fight viruses and bacteria. So here's a nice little cartoon from the British Society of Immunology. So what it shows is an antibody. So an antibody is produced by these white blood cells, and it kind of recognizes and attacks invading bacteria and other foreign organisms in the body. And normally that's what they go for, but when we get autoimmune encephalitis, instead of targeting those microbes, we're targeting ourselves. Right, I think my slides are finally going in the way that I want them to. So these autoantibodies are really the root cause of what's going wrong. So if we think about in the brain, we've got these cells, neurons, that communicate with each other, and through that communication really are the sort of foundation of our behavior and personality and kind of conscious being. The autoantibodies that are found in autoimmune encephalitis, they attack proteins that are on the surface of these neurons. So if you can imagine on these neurons, particularly in the sort of synapses, which are over in this part here, there's lots of receptors and other kinds of molecules that help the communication between those neurons. And these are the entities that are attacked in autoimmune encephalitis. So if they're not working properly, then you can kind of extrapolate from that we're not thinking properly, that it's affecting our ability to function normally, and also that it could cause seizures as well. So what are the root cause? So first of all, because I'm going to talk a little bit about genetics today, there are no cases that we know of that are inherited. So I always say this to people when they come to our centre: please don't worry. We don't think this is going to be passed on to your children or other relatives. There are some known associations that we do know. So first of all, infection with herpes simplex encephalitis. So I think a few people in the audience said they had infectious encephalitis, which in this country is most likely to be herpes simplex. And we now know that after an episode of herpes simplex encephalitis, there is a risk of developing autoimmune encephalitis, and particularly a particular form known as NMDA receptor antibody encephalitis. And that will happen within a sort of couple of months of the infectious episode. Another trigger of NMDA receptor encephalitis is a tumour. So there's a particular type of tumour that mainly affects the ovaries in women called an ovarian teratoma. And sometimes if you have that type of tumour, it can give rise to these antibodies and cause NMDA receptor antibody encephalitis. There are other associations as well, but those are the main two ones for NMDA receptor encephalitis. But even those altogether only make up about 30% of cases of NMDA receptor encephalitis. So that still leaves 70% where really there's no obvious trigger that's found. And that's some of the work that our group is trying to do. So I talked a little bit earlier when I was still rather confused about my own slide presentation about some of the symptoms in autoimmune encephalitis. So now I'll try to talk through those in a slightly more organized fashion. So here's just a kind of global picture of the human brain, and the part that's highlighted in green is known as the limbic system. The limbic system really controls very much sort of emotions and behavior. And that is typically affected in many forms of autoimmune encephalitis. So that can cause some of the memory deficits, because if we look at this part here, the hippocampus, that's got a very important role in memory. So often people with limbic encephalitis will say they can't remember things, particularly short-term memory, but sometimes longer-term memories as well. Seizures we've talked about because we're interrupting the communication within the brain of those neurons. So that can cause a sort of abnormal firing of neurons, which can lead to seizures. Altered conscious level, so people can become less aware than usual, and in really extreme cases that can mean that you're needing admission to the intensive care unit. Abnormal movements, because the brain obviously controls motor function. So if that's disturbed, one can have abnormal movements. I did have a video of that to show later, but apparently it crashes the system. So unfortunately, we won't be able to show that today. And psychiatric features, which we touched on earlier, which is really sort of personality change. And changing how you're sort of with your family and friends. But typically it's more than one of these features. So often with limbic encephalitis, it might start with a sort of subtle change in personality or mood. And then as the symptoms continue, it might become more prominent, and then seizures might start. And that's often when it becomes really obvious that something is gravely wrong. I've also forgot to put my timer on, by the way, Philippa, so I'm really sorry. My timing's a bit off. Okay, so we've got some little lightning bolts there showing where everything could be going wrong. So I'm going to talk now about 3 subtypes of autoimmune encephalitis, which are the most frequent ones that we see in our clinic. NMDA receptor encephalitis, LGI1 antibody encephalitis, and Caspr2 antibody encephalitis. So NMDA receptor encephalitis is quite often happening in younger women, so under the age of about 45, slightly more affects women than men, particularly in that younger age group. And that's the one, if you remember, that can be associated with these ovarian tumours, and also sometimes after an episode of infection. So typically in that form of encephalitis, there'll be behaviour changes, often mood changes early as well. So people with this form of encephalitis sometimes are seen by psychiatric services first, because the main change might be mood or even psychosis, having hallucinations and things like that. Seizures and a movement disorder, which is what I referred to earlier, so making abnormal movements. LGI1 antibody encephalitis is a slightly different type, typical presentation. So the typical patient is a man, is his sort of maybe mid-60s, and there's slightly more men than women that are affected with this. And there's a very characteristic type of seizure, which I think we'll see on the next slide, called faciobrachial dystonic seizures. So that's a very brief movement. It typically affects the arm, but it can affect the face and the leg as well. And it's kind of like trying to do a bit of a demonstration. A jerk happens very suddenly, sometimes can be with a decreased level of consciousness, but don't completely lose consciousness, and can happen many hundreds of times a day at the sort of most extreme end of the manifestation. And there is a genetic link, which I'll talk about in a minute. And Caspr2 antibody encephalitis also affects men. In fact, the male predominance in Caspr2 antibody encephalitis is even more pronounced than in LGI1. They do not have faciobrachial dystonic seizures, but they do have seizures, and often there can be pain and what we call peripheral nerve hyperexcitability, so cramps and kind of funny looking rippling of muscles in the legs. And there's also a genetic link. So when I say a genetic link, this is what I'm showing on this graph here. So we all in our body, on our immune cells, carry a particular protein that's really involved in essentially showing to other immune cells if you've got sort of a bad guy, a microbe circulating. So these particular proteins will sort of basically pick up bits of microbe and present them to other immune cells and say, well, this is what I found. And then the other immune cells will all sort of go off and do their activity. So what our research has found, I don't know if people can still hear if I move towards the... Not virtually, sorry. Not virtually, okay. So I'll try and use the clicker. There we go. So if you carry this particular form of this immune protein, 90% of people with LGI1 antibody encephalitis will have this particular form of the immune protein. And if we look at Caspr2, 50% will have a different form of that same immune protein. Now, I don't want people to worry unduly, because what this also shows is that in healthy controls, about a quarter of healthy controls also carry this same immune protein as the LGI1 patient. And about 10% of healthy controls will also carry the same immune protein as the Caspr2 patients. So what this tells us is that having this particular form of the protein increases your risk, but it doesn't mean that you will definitely get that form of encephalitis. It's just one part of the jigsaw that we can say having that immune protein is one risk factor, and there's probably lots of other little steps that you have to go through to then unfortunately have one of these forms of encephalitis. But this kind of knowledge can help us start doing the research to know the ultimate root cause of disease. So hopefully this will work. So this is a faciobrachial seizure. How do I click to get it to play? Oh, it's going to play. Right. So could you see on her right side there, that very sudden movement? We should do it. Okay. There's another one. So it happens very suddenly. It takes the patient often by surprise. I think on the next slide, we'll talk a little bit more about that. If I can get this to move on. So this was some work that was presented at the Christmas meeting of the Encephalitis Society called the messy carpet sign. So essentially, when patients have faciobrachial dystonic seizures, as you've seen, they're quite violent and they can happen, you know, quite unawares. And they can cause accidents. And we found from our clinic that about half of patients with faciobrachial dystonic seizures had kind of domestic accidents. So often it's spilling tea or coffee. So people tell us that they've spilled tea or coffee on a carpet, had to have their carpet replaced. More seriously, people have actually spilled hot drinks on themselves. And in one case that I know of, actually had quite bad burns as a result. People have spilled wine, dropped food, tore clothing because of a kind of violent jerk, and a couple of people have had bad accidents actually in the bathroom from sort of jerking back onto a piece of bathroom furniture. So this is something that we've observed, and we talked about it actually in December as perhaps something that, you know, if it's happening a lot and people having these jerks and spilling things and having accidents, that's maybe a sort of early warning sign, maybe something that's sort of worth letting doctors that work in emergency department or GP, for example, know about, just as something to have that little thought process. Oh, I've seen this patient that's having these types of events. Maybe it could be something that needs onward referral. Because about 2/3 of patients with LGI1 antibody encephalitis do have these types of seizures, and they are very frequent. So if we look at the pie chart, so I'll try not to move from the microphone, the pie chart here, this is showing the different numbers of seizures per day. So you can see about 40% are having 1 to 50 per day. That's still a lot, but actually as we go up, 17% are having 51 to 100 per day, 20% are having up to 200 per day, 17% are having 200 to 499, and there's even a small group who are having more than 500 episodes per day. So, you know, this is a large number and really distressing for the patients and families concerned. Luckily, there is treatment, which I'll come on to shortly. And just to kind of continue with the sort of impact on patients and families of these events, this is actually an excerpt from a family diary of a patient that was having faciobrachial dystonic seizures, and the family has documented, this is just a couple of pages, but there was quite a long diary of this, all the different things that happened to this poor lady. So, you know, spilt cup of tea on herself, for example, fell, and we do see this falls. And then on this day, spilling tea again. And then they've called the faciobrachial seizures body jolts, which is one way. Sometimes people call them jerks and other names. And you can see from 4 o'clock, she's had one, 5:30, 5:45, 6:05. So they're happening quite frequently. Okay, so how do we diagnose autoimmune encephalitis? So first of all, we have to recognize the symptoms. And as I've said, those are mainly sort of personality, memory, and seizures. And then a number of investigations will take place. So we'll always do some blood tests, and we can test for the antibody in the blood. And I'll come on the next slide about how we do that. And we'll do an MRI scan. And here's a typical picture of limbic encephalitis here, where you can see, so this is what we call the medial temporal lobe, which is where that hippocampal area is that controls memory. You can see it's kind of quite bright compared to the rest of the brain. So that's just showing signs of inflammation. I've got 5 minutes left. Okay, I'll try and speed up. I don't think I've got that many more slides actually. But we don't always see an abnormal brain scan. So sometimes, particularly in NMDA and LGI1 and caspar-2 encephalitis, the brain scan can be normal actually at first, so it doesn't rule it out. We'll do a lumbar puncture, so that's where we put a needle in the back and take out some spinal fluid. And for that, we can look at whether there's cells present, and we can also test for the antibodies in the spinal fluid. And sometimes people will have what's called an EEG, so that's looking at the brain waves, essentially looking to see whether there's any seizures. Sometimes we can pick up what we call subclinical seizures, so somebody might not be having seizures obviously, but they might be having very little seizures that aren't obvious to sort of outward observers. We can do questionnaires to see how someone's doing, and we can also do a full body scan to exclude an underlying tumour. So that will typically be done to check there's no tumour association of the encephalitis. So I'm just going to explain how we test for the antibodies in our lab. So I'm going to go through this cartoon here. So we grow cells called HEX cells in the lab, these human embryonic kidney cells. They're grown in culture plates. And then those cells are engineered so they express the protein that the antibodies are being made against with a fluorescent green tag. So this is essentially this picture down here. So you've got cells here, and they've been sort of genetically engineered really to show these green proteins. We then apply a patient sample. That can be serum or it can be CSF. If the patient has antibodies to that protein, those attach. So this is this little antibody here. Oh dear, I've gone too far ahead. And then we apply another antibody on top of that, which is this one here, which has got a, sorry, it just wants to go on, doesn't it? It knows I'm running over time. It's got red on it. And so you can see here, someone that has LGI1, their sample will produce this red effect, where the red has clung onto the patient antibody and produced that image, whereas somebody that doesn't have the antibody will look like this one here. So that encephalitis should actually be under there. That's an error on the slide. And if there's other antibodies present that aren't specific to the protein, then those antibodies get washed away and they don't bind, so you don't see a signal. So I want to talk about a bit about treatments. So once an infectious cause has been excluded, the mainstay of treatment is immunotherapy. So what we would typically do in our clinic is start with intravenous steroids, quite a high dose, and then we would add oral steroids after that. And then we typically do plasma exchange. Some centres will use intravenous immunoglobulin, which is an alternative to plasma exchange. And obviously, if a tumour is found, then that would be removed. One thing I wanted to mention is that rituximab is coming more and more into use. So that's a medication that targets B cells, which are the cells that make the antibodies. And we're more and more using that, particularly in NMDA receptor and LGI1 antibody encephalitis. And we're finding that's quite an effective way of treating these conditions. Because what you can see from this graph up here is that, so this is a graph showing people having the faciobrachial dystonic seizures that I mentioned and time. And the red line is if only anti-epileptic drugs are used. And the blue line is if immunotherapy, such as steroids or plasma exchange, is added in. So what you can see is that if you do that dual therapy, oh crikey, the seizures very quickly drop off compared to just having anti-epileptic drugs. The graph below, which I won't go into too much detail, but I'm happy to take questions, really shows, and I've already been asked about this today, some of the long-term effects of LGI1 antibody encephalitis. We know that people do on the whole very well, but there are some sort of subtle problems that can continue after the acute phase. And this was a paper that was published within about the last year. And what we showed from that is quite a high rate of things like fatigue that carry on after the acute phase is over. But if people have questions about that, come and talk to me after, because I don't want to run out of time. So this is just some of our papers that have looked into various aspects of autoimmune encephalitis. So I've just talked to you about early treatment leading to better patient outcomes. I've talked about quality of life. The fact that there are these sort of longer term impacts. And there's just a quote here from a patient, actually, which I think is, I remember meeting this chap, quite a moving quote, who said, because of his FBDS, he was terrified to do anything, even make a cup of tea, or if someone would speak, he would get what he called a spasm. And he would get a spasm if he was quite excited. So he was a big football fan. And if he watched a particularly excited football match, he actually wouldn't want his team to score because he'd be worried that he would get a spasm. And that was the impact of living with this type of seizures in a sort of 60-ish-year-old chap. The research below, this just shows our lab is looking into which areas of the body are particularly active in producing autoantibodies, and we found that lymph nodes might be one such area. They're little sort of centers. These ones were found in the sort of lymph node type areas in teratomas, but we're now looking into lymph nodes in the neck as well. And this study looks at what stage of their life the white blood cells are producing the antibodies. So whether it's new cells that have just come out from the bone marrow, whether it's ones that have been in circulation for a while. So this just sums it up, really, different areas of research. So we're researching cells and antibodies in the blood and in the spinal fluid. We're also starting to look more and more into these lymph nodes that I just mentioned. There's just an image of someone having some cells aspirated from the lymph node in the neck. Bone marrow has been explored, and my particular work looks at genetics, which is illustrated there, and we're doing more genetic studies. I think I'm nearly out of time, so I'm going to very briefly mention we're also doing a new clinical trial in Oxford for LGI1 antibody encephalitis as well, which new patients potentially, if they see us in Oxford, can be enrolled in. Right, I think, did I just about make it? I'm sorry, I was a bit haphazard at the beginning. I felt like this, my whole slides were dashing before me. I didn't know what was happening.